Bonjour, Ani, Sego, welcome. This is using our voice, Module 1, on Indigenous patient experiences. Throughout these modules, we're going to be looking at Indigenous patient experiences and the role of racism in the harm and unfair, unjust experiences that we have within the healthcare system. This module is going to be looking at why we need to speak up about unfair poor care within the healthcare system and the harm Indigenous people experience. So answering those questions, who are you? Where are you from? Who is your family? Questions that I always had asked of me whenever I was out and about and someone recognized me as Indigenous. So my status card name is Jodi Rock. I am a registered band member with Mississaugas of the Credit First Nation. My grandparents, so my mom's parents are Bernice and Alice Tobacco. Through my grandmother and her mother and her mother and her mother, my lineage is actually Six Nations of the Grand River, Mohawk, Turtle Clan. Registered under my grandfather, so that's how I end up being a band member of Mississaugas of the Credit First Nation. I do consider both Six Nations and New Credit as my home communities. I also grew up off reserve, lived off reserve my most of my life, so I consider the urban Indigenous community my home as well, my home community. I'm a mom to four, I'm an auntie to four, I'm a great auntie to four, I have four four-leggeds in my home. So yeah, about me in my work. For more than 15 years, I've been working in patient advocacy, partnership development, engagement with Indigenous communities, and facilitating Indigenous cultural safety learning. Right now, in April of 2025, I currently hold the role of Indigenous Health Liaison with Mississaugas of the Credit First Nation. So I have this slide in here, who are we? So this is who are we as an Indigenous people. One thing that I want to acknowledge is the various terms that have been assigned to us as Indigenous people. So the inhabitants of Turtle Island or North America prior to the arrival of settlers. So in the past, it's been Aboriginal, it's been Native, it may have been Indian back when I was young, and that term is still used in the Indian Act, for example. You will hear me reference myself and our people as Indigenous people. I like that term myself because it describes the relationship to the land prior to colonization. It also creates space for different nations to identify themselves in ways that make sense to them. So Mississauga of the Credit, being an Ojibwe nation, Anishinaabe is how we refer to ourselves. Six Nations of the Grand River, you may hear them say they're Haudenosaunee or Ongwahome. So you may hear different ways that Indigenous community would like to reference themselves. So for us, Mississaugas of the Credit First Nation, at one time we were stewards over a sizable portion of southern Ontario. So 3.9 million acres. You'll see on the next slide our treaty maps. Settler encroachment and frankly, settler violence. We forced my ancestors from an established location. So this is Credit River, Mississauga area. We had settled there. We had hopes that we would be there for time immemorial. A very prosperous settlement area for us. We were actually forced to our present reserve location near Hagersville, Ontario. We share borders with Six Nations of the Grand River. So you'll see here, these are some of our treaties. Yeah, so the Crown recognized Mississaugas of the Credit as treaty holders for all of this area. When we moved from our settlement at the Credit River, we numbered mid-200s. So this is including adults and children when we moved to our present-day settlement on the reserve. Now we're around just over 2,000 strong in membership. So I want to recognize that amongst Indigenous people, there's great diversity. So there's different nations, different origins on Turtle Island, so different places where nations may have migrated from, migrated to. There's different languages and cultural practices. One of the things that I notice Ontario Health is doing is they are using FNIMUI as a way of recognizing this diversity. So they're not only acknowledging First Nations, Inuit, Métis, but they're also recognizing the urban Indigenous community, which for me, is important because our needs are different. I have different barriers and challenges and benefits than my family members living on reserve do. You may hear me use the term settler as we go through this material. So it's something that I did not hear 10 years ago, something I've only started to hear over the last couple of years. But really what the term settler, versus Indigenous people, what it does is, again, it speaks to that connection to the land prior to colonization. So if, somebody has been here and they've been here for 3 or 4 generations, or, their family came over and settled this area, even though they were born here, their parents were born here, their parents may have been born here, looking at the relationship to the land prior to colonization, they would still be considered settlers. This terminology, I think it centers the relationship to the land in a way that honors Indigenous inherent rights and ways of knowing, being, and doing. You may also hear me speak of Indigenous-led and non-Indigenous-led. So it's just my way of reminding myself and those that may be listening that Indigenous health belongs in Indigenous hands. So whenever an organization or body is governed by settlers, I'll use the term non-Indigenous-led. So first off, why do we need to speak up? So as Indigenous people, why do we need to speak up about our experiences within the healthcare system? Very simply, to honor those that have come before us, those that we are gifted with now, and those faces yet to come. On the top left there, you'll see my nanny. So this was my grandmother, Alice Tobacco. She was raised off reserve. Her father was a product of the residential school system, and he believed it was in their best interest to try to blend in to the white world as much as possible. So even though she was raised, her mom was a fluent Mohawk speaker, her mom attended Longhouse, carried ceremonies and everything forward. It was not something that was practiced within the home. I remember growing up and hearing my grandmother speak Mohawk with visitors, and then, wondering after, why is that the only time that I heard her speak that, and what is she doing? So she was not comfortable in fully embracing who she was for most of her life. My mom, down in the bottom left, this is during her palliative care journey, she experienced a lot of racism in her life and discrimination. In the middle there, you see myself and 3 of my children. My children are starting to step up now and name things like white privilege and racism and the influence of stereotypes. And I think that's why we have to speak up, is so that they can see us modeling, how to address this injustice and this harm in a good way. And in doing so, the hope is that the experiences of those youngsters on the right, the bottom right of that slide, will be far different. So that is myself and my brother's grandchildren. And my hope is that when they are engaging with the healthcare system, their children are engaging with the healthcare system, they won't be experiencing a lot of the same harms that we have experienced in the past and that we're continuing to experience today. So we're going to talk a little bit about the harm. Like I said, as Indigenous people, we operate in this world experiencing judgment, bias, prejudice, stereotypes, discrimination, looks, like we live with this on a daily. I especially notice that being off reserve, something that I've lived with my entire life. in my family, you've heard things about, horrible experiences at the hospital, or, this doctor said the whatever, did that to me. We may hear it amongst our friends and our close family and our community, but we don't often have national attention brought to our experiences like these three individuals have. So we're going to talk a little bit about Brian Sinclair, Joyce Echaquan, and Heather Winterstein in the upcoming slides. And just to give you a little bit of notice, this information, if you haven't heard the experiences, it can be quite emotional to really sit with what these people have experienced. And I would just like to take a moment to encourage you to not only practice good care of yourself if you're learning about this or revisiting this, but also to just sit in that discomfort. So just to sit with those emotions that may be coming up, because it's those emotions that are going to be the energy and the passion to really make change, take action to make change. So first we're going to talk about Brian Sinclair. Brian Sinclair was a visibly Indigenous man that was seen by a doctor at his community health center. So Brian Sinclair had gone to the community health center, and the doctor that had looked at him identified that his catheter needed attention, and it was something that they were not able to do at that community health center. They just weren't equipped to provide that level of care. So the doctor wrote some things down, gave it to Mr. Sinclair, and said, you need to go to the emergency department, give them this piece of paper, and that will tell them what needs to happen. They'll take care of you. Mr. Sinclair had spent some time unhoused. He was housed at the time of his death, and had also spent some time with substance misuse or dependence. But at this time, he was actually doing, quite well, and this minor thing that needed to be done shouldn't have become the issue that it did. So he presents to the Health Sciences Center in Winnipeg. There's a lot of videos online that show his progression through the emergency department. So you see him rolling up to the triage desk, you see him having a conversation, and you see him going to the waiting area. And for the 34 hours that he's there in that emergency department, you can actually track his movements throughout. And part of what Mr. Sinclair experienced were, bystanders that were witnessing his decline and witnessing how sick that he was appearing and how he wasn't getting attention. So they were bringing attention to that, and they were being told things like, well, he's homeless. We think he just needs a place to be warm and watch TV. He's okay. At one time, he was vomiting, so you can see the bin in front of him there. The medical staff did not go and check on him to make sure that he was okay. What they did is they sent the janitorial staff to clean up the vomit, and he was left sitting there. So how he was discovered to be dead, there was a woman and a child, so a settler woman and a child that was there in the evening, and had noticed that he was just not looking well. So she tries to bring attention to this and to get somebody to look at him, and it falls on deaf ears. She decides to go home because the wait line was too long. She returns the next day, and she sees Mr. Sinclair not looking well at all. So she alerts security, and there's something terribly wrong with this man, and they realize that Mr. Sinclair is in fact dead. So he sat dead in his wheelchair in that emergency department for 2 to 7 hours before being discovered. Rigor mortis had already started setting in, and he was ignored to death. His cause of death was sepsis from a treatable bladder infection. So there was an inquest that was called. So an inquest looks into things that contribute to a person's death. It looks at the medical records. It's an investigation. So there was an inquest called, and even though health sciences staff members were saying, "Oh, I thought he was drunk and just needed a place to sleep it off. I thought he was homeless, and I was doing him a favor by just letting him sit and watch TV." Even though these things were being said by the healthcare staff, the role of racism was lightly considered, but it wasn't named as a contributing factor in his death. What the inquest focused on, the report focused on, was the patient flow in ER. So some of those processes, like patients need to do this and this and this, and staff are doing this, and staff are under resourced. There's not enough people. They're overworked. Blah blah blah. That's what it focused on instead of the role that racism had in his death. So this was in 2008. We're going to fast forward. We're going to come up to 2020. So 12 years later, Joyce Echaquan presents to a hospital in Quebec. Joyce had been experiencing intense abdominal pain. She had seen a doctor the day before. The doctor had noted assumptions that she was in withdrawal. So she was detoxing from substance. There was no medical evidence that was the case for her. In her experience with the emergency department staff, she did become upset. She became upset because she felt like they were not paying attention to the fact that she had issues with some pain medication. So she felt strongly that she was being over medicated. She was trying to bring that attention to staff. She had some instances in the past where outcomes were quite scary with this over medication. The staff responded by tying her to the bed. So in the final, time of Joyce's life, she had reached out to family and friends to see if anybody could come and sit with her because she was afraid. She didn't like how she was being treated, and she was afraid that they were, not treating her well, and she was going to be harmed. Because of that, a family member was on the way. She decided to live stream her experiences. So she went on Facebook Live, and she had the phone kind of recording inconspicuously, so it was not something that the nursing staff or the medical staff were immediately aware of, but they were recording what and live streaming what they were saying about her. It is hard to find, but you can find online a recording. Like, you can actually listen to the recording and see the translation of what they were saying, but they were essentially referring to her as worthless, good for nothing Indian that just pumps out kids. Why do we have to look after these people? Those types of statements. And these are things that Joyce is hearing around her as she's laying in her hospital bed and dying. So the family member or friend does arrive and discovers that Joyce has died, and discovers that she died tied to the bed with this live stream happening. So I can't imagine what it was like to be Joyce in those final moments and to hear, the people that you're looking to take care of you and to restore you to health, to actually hear them saying those horrible things, and for her family and her loved ones to actually witness that as it's happening. Like, it just hurts. So such an awful experience. An inquest into Joyce's death, it did name that racism contributed to her death, and that was, subsequently denied by the Quebec government. And no, it doesn't happen. There's no racism. There's no systemic racism within Quebec. That's Joyce. Skip ahead a little bit. A year later, 2021, This is the experience of Heather Winterstein. Heather Winterstein was a young Indigenous, a young Indigenous female. She was around the same age of my daughters when she died, so she was mid-20s. She went to the emergency department because she was experiencing intense pain in her back. So her first visit, she was given a bus ticket and was sent home. The bus ride was 90 minutes, about, give or take a little bit, but it was 90 minutes that she had to ride this bus home. She was told to take Tylenol, and was basically dismissed. So, we fast forward hours later, half a day, whatever it might be, that she's still experiencing this intense pain. She goes back to the ER via ambulance, and she collapses and dies in the waiting room. The cause of her death was a strep A blood infection. So again, something that was treatable. Had it been located, in her first visit, totally preventable death of a beautiful young Indigenous woman. There is an inquest in progress. But yeah, so these are very public cases. This is all public information that's out there, but not all of the experiences that we have will receive that type of media attention. So taking a moment just to sit with those feelings that have come up. Like I said earlier, to really lean into the emotion can help us be better motivated to take action. And that's what I'm hoping will come out of these modules is, the motivation to take action, the willingness to take action, and later on we'll look at, what that action can look like. So just taking a breath, taking a moment before we switch gears. I know that's a lot of information that is hard on the heart. So looking at those experiences, the question comes up as to why is this racism towards Indigenous people such a big problem within the healthcare systems? When we dig a little bit deeper into what racism actually looks like, the bias, the stereotypes, the prejudice, you'll see how some of those narratives have played into the experiences of Brian Sinclair and Joyce Eschquan and Heather Winterstein, and hopefully you'll be able to even name the stereotypes that were having influence in their experiences. But before we get into all of that, we need to look at where are the roots. So where are the roots to this racism that Indigenous people experience, the colonial context around the healthcare system. So looking back at Canadian state documents, so government documents of the mid-1800s, Indigenous people were described as mentally inferior, childlike, unpredictable, untrustworthy, and violent. So you'll see ahead as we dig deeper into, those common stereotypes and prejudice that's towards Indigenous people, a lot of these, descriptions still carry weight today. People are still looking at Indigenous people as violent. They're still looking at Indigenous people as mentally inferior, not capable of understanding or caring for themselves. So that childlike, the unpredictable, they are still living and breathing. These descriptions of Indigenous people are still living and breathing and alive and well in today's society. So when we look at the colonization of what is now known as Canada, at its core, it required racist beliefs about and practices towards Indigenous people. So the whole idea that a settlers could come in and take over the land and dictate to Indigenous people, policies and to really take control the way that they did in such an oppressive way, it requires those racist beliefs. So the racist beliefs of inferior, like less than, right? Indigenous people are less than, they're less than human. You're going to hear me reference a lot First Peoples second class treatment. So, that's a report that was put out around the time of Brian Sinclair, maybe just before that. But yeah, you'll hear me bring a lot of those words into this presentation. As I was doing patient navigation, I knew that our people had these experiences. I didn't have the language to fully describe what was happening, and it was First Peoples second class treatment that gave me the language to talk about some of the things that we're going to be talking about today. So we're going to look at some of those policies and practices that had racist beliefs at their core. So we're going to look at Indian residential schools, so operating from 1831 to 1997. How many years is that? That's like 166 years. Over 150 years, we'll say. 1831, it was the first residential school in Brantford, so the Mohawk Institute. It wasn't until 1883 that the government actually had legislation and policy that described why it was necessary to kill the Indian and the child and outlined how it was going to be done. So that involved the forced relocation of Indigenous children into these schools, deliberate disconnection from family and community, and deliberate practices within those schools to kill the Indian and the child. So punishment for speaking language, all of the horrible things that more people are now more aware of today. What a lot of people may not be aware of is the medical experimentation that happened within those schools. So often the schools and the hospitals were in close proximity. One of the more well-known experiments that come out, and you see here children getting supplements, but because of the deliberate underfunding and the poor nutrition, Indigenous children were deliberately starved to support nutrition research. That was really huge for me to kind of learn that, because it has present day connections to type 2 diabetes and why our bodies may be prone to hang on to fat, to convert things into fat, because my ancestors were starved generation after generation after generation. They were starved, so it changes how our bodies respond to food. So these residential schools deliberately underfunded, sources of horrific neglect and abuse. We go into Indian hospitals. So 1936 to 1981, Indian hospitals first came into being to protect settler society from the spread of TB. The government officials, policymakers, Indian agents, all those people recognized that TB was spreading more rapidly within our communities, and they made an assumption that it was because we were inferior. Like that, it was something to do with us, like our race, that made that possible for the disease to spread so rapidly. They overlooked the fact that the poverty that we were forced to live in, the forced dependence on government rations, the disconnection from our traditional food sources, all of those things were not taken into consideration. So the idea was, we need to protect settler society because those Indians keep getting sick, and they're going to keep getting sick because they're less than, they're inferior. So what we're going to do is we're going to forcefully relocate them from their communities. We're going to put them into these Indian hospitals. We're going to disconnect them from family, and we're going to punish them if they're not complying. So Indian agents actually had the power to have people penalized by the criminal justice system if they weren't agreeing to go to the Indian hospital. So they would perhaps take away their rations, or they would bring in the RCMP to force that relocation to Indian hospitals. Oftentimes, community members were taken far from their communities. They were held in these hospitals for much longer than necessary. There were treatment options like medication that were effective against TB, but Indigenous people within these hospitals were denied those therapies. Settlers, what they were experiencing is they were able to get medication, resume their lives, take this medication. There was a belief that Indigenous people weren't capable of taking those pills or whatever that medication was, that they would be non-compliant, and that the disease would continue to spread and potentially put the settler communities at risk. So they were held within these institutions. There was medical experimentation that was done on them. You'll see in a little bit later on, we talk about Maureen Lux. She's a scholar out of, I believe, Brock University, and she talks about her experiences learning about Indian hospitals from survivors, and how one man had known that he was missing a rib, but he didn't understand why he was missing a rib. He had no recollection of anybody saying to him, hey, I'm going to take your rib out. But later on in his adult life, when he's learning about some of these things that happen at Indian hospitals, he learned that it was an experimental practice related to TB. And it was something that he never consented to. He wasn't informed of. He just grew up, at some point realizing that he had one less rib than what he should have had. So there was experimentation that was done within these Indian hospitals, again, without informed consent of the patients. They were deliberately underfunded, so that meant they got, the doctors and the nursing staff that were, kind of at the bottom of the barrel. There was substandard care. The facilities themselves were dilapidated, so they would be dealing with things like mold and that type of thing. The inadequate resources, so they didn't have what they needed to have to provide quality care. And like I said, the forced disconnection from community, what often happened is when the hospital was saying, okay, you can go now, there was no effort taken to return that Indigenous person back to their home community. They were essentially discharged to the street. And in this case, this could have been many, many thousands of kilometers away from their home communities, but they were essentially, kicked out onto the street. So we look at recent times. Some people may say, well, that was ancient history. Again, when you look at the dates, it's not all that long ago. It was within our lifetime that people have experienced both residential schools in Indian hospitals. But the tendency, I guess, for settlers and maybe some Indigenous people themselves to think is that was way back then. Things aren't like that now. But really, when we look at what's happening today within the healthcare system, these days you see a lot of media attention given to the cases being brought forward by Indigenous women in Canada that were forcibly sterilized. So they were actually coerced by doctors, or they were sterilized without their knowledge, and later finding out that ability to have children was taken away from them without their consent. So you see a lot of that in the news now, where people are coming forward and bringing those cases forward. There's a headline here from, when is it, from 2019. This is the death of a 19-year-old First Nations man found near Thunder Bay hours after his discharge. So recently, I was visiting a city and I was going past the hospital, and a friend pointed out that hospital and how he didn't want to go in there. He was recently sick, but he didn't want to go in there because he had heard from Indigenous community that there was a young Indigenous person that had gone seeking help for suicide, risk of suicide, and they were essentially turned away and put back out on the street to follow through with completing suicide. So, again, that belief that they don't care about us, I don't want to go there because I'm not going to be taken care of. So it's a very real fact today that our people are being pushed out of the doors of these institutions like hospital, even into situations where there's a great risk of harm and even death. They're just getting shoved back out into the street. Our healthcare services are deliberately underfunded within Indigenous communities. So when we look at, what municipalities are getting compared to what maybe the reserves are getting, there's a big difference in that. We're also looking at forced relocation, disconnected from family and community. In my work a few years ago, with a homeless shelter, what I noticed is that some of the Indigenous people that came because they were homeless were actually coming to Hamilton from the north, because they didn't have the medical services that they needed in their communities. So they had to relocate south to get the medical care that they needed. So they were living with that disconnection from family, community, and in the cases of just arriving here, homelessness was something that they needed to deal with. So within, hospitals and healthcare institutions today, we're still seeing that mistreatment and abuse. We'll talk about birth alerts a little bit later, but the forced sterilization is an example. Joyce, Brian, Heather, they're all examples of the mistreatment, the denied assessments, so they're being denied treatment in present day. So yeah, and not being returned home. I just spoke to a friend this morning that talked about their experience going to, again, this person's living on reserve, going to experience in hospital off reserve, and them being discharged in the middle of the night with no way home, and how the hospital did not provide any support, basically just essentially kicking them out into the street and expecting them to find their own way home, and how frightening it was that they couldn't find a ride at 2 a.m. in the morning because their families and their friends were sleeping. So looking at the practices of hospital today, those types of things are still happening. So one of the reasons why I want to do these webinars or these videos is because today we have people listening. 10 years ago, being out as a patient navigator and bringing attention to some of these things, hospitals didn't give a darn. Like, honestly, it was on deaf ears. It was, yeah, like, well, we'll just provide smudging and everything will be good. But now things have changed. There's a lot more attention given to the influence of racism within the healthcare system and the harm that Indigenous people experience. So years ago, when the structure, the financing or the governing structure of healthcare systems changed, and we shifted to OHTs, Ontario Health Teams, in those requirements for Ontario Health Teams to form, they were being asked to outline how they were going to provide culturally safe care to Indigenous people. So all of these Ontario Health Teams that we see, operating today, they had to go through that process where they had to think about Indigenous patient experience, and they had to think about what they were building within their team to ensure that Indigenous people were receiving culturally safe care. Past funding agreements. So a few years ago, one of the things that I was able to see was how the HNHB LIN, so this was prior to the Ontario Health Team, they outlined requirements for staff training in Indigenous cultural safety. So they were saying, we're going to give you funding to run this program or to deliver this service, but we are requiring staff to participate in Indigenous cultural safety training. So we are requiring staff to learn about how colonization impacts the health and social outcomes of Indigenous people today. So, why Indigenous people experience what they experience today. And also, part of Indigenous cultural safety training is looking at racism. It's anti-racism training. So that was a requirement maybe, I don't know, 8 years ago. Now, within present-day funding agreements, hospitals are being hospitals are being required to advance Indigenous health strategies and outcomes. So this is written right into the funding agreements, that they will advance Indigenous health strategies and outcomes, and they are being asked to report on that. So what does this mean? Hospitals are being asked to take steps to increase cultural awareness, which is a better understanding of who we are as Indigenous people. So, hospitals are required to do things to deepen that understanding of Indigenous people, our history, our ways, our medicine practices, our challenges, the barriers that we experience, all of those things fit into cultural awareness. They were also being asked to take steps to increase cultural safety. So their funding agreements are saying you need to demonstrate with this funding that you need to demonstrate that you're going to be addressing the racism within the system, the practices, and including service delivery. So you're going to have to report back as a condition of receiving this funding. You're going to have to report back on how you are increasing cultural awareness and how you are increasing cultural safety. So hospitals are listening. Ontario health teams are listening. Okay, they may not be quite there yet where they're fully accepting, appreciating, and taking action, but they are in those stages of being interested in listening. And it's not something that comes and goes with certain people. It's attached to their funding. So yeah, that's something to keep in mind, that people are listening today. So we need, as Indigenous people, we need to step up and we need to speak about our experiences. The funding agreements are asking also for hospitals to report on programs that foster Indigenous engagement, what has been developed in terms of an Indigenous health plan, and all executive level staff, so all those higher up leaders, they're required to take Indigenous cultural safety training now. Through these funding agreements. In response to this, some hospitals are rolling out Indigenous health departments and positions that support reconciliation, or the calls to action. Those things that have been put out there that say this is what needs to be done. So some hospitals in this area, you see it with Brantford, we see it with Niagara. Niagara's been operating an Indigenous health department for about 2 years now, and there's a position rolling out within St. Joseph's Hospital in Hamilton, St. Joseph's Healthcare System, in Hamilton. So you'll see more of these positions roll out, and really the work of those positions is to look at that engagement. So really, connect with Indigenous community and, hear what it is that they need, that they want, learn about their experiences, and take action to shift those experiences to being safer and more supportive of Indigenous health. Hospitals are also being asked to demonstrate what they are doing that results in improvements across Indigenous health outcomes. So there's a big ask for hospitals, and in order for them to follow through with some of these tasks, they need to hear our voices. They need to learn about our experiences. They need to learn about our communities. So some of these calls to action, this is just the Truth and Reconciliation Commission calls to action, the health that are 18 to 21. This is my own language. It's not quoted because it's, highlight plain language as much as possible. But call 18 is to recognize the colonial roots of Indigenous health and social outcomes today, and to recognize that we have an inherent right to practice our ways. So this is really taking steps to learn and understand how colonization has disrupted our own systems. We always had ways to maintain individual and community health and well-being. We did not need the settlers to come and tell us how to take care of ourselves. We always had that. what happened with the settler interference is the outcomes that we see today. So the settler interference that resulted in us being disconnected from our communities, our culture, our ways, our traditional ways of doing and knowing and being, it has resulted in the outcomes that we see today, in terms of mental health issues like addiction, like substance misuse, sorry. Um, the forced displacement of our people, like so many colonial practices and policies have resulted in why we have those gaps, and differences today, that we see between Indigenous health and non-Indigenous health. An example of that, I learned just recently, they were looking at comparing the lifespan, so the average lifespan of a non-Indigenous person. I think it was up in the 80s, and they asked what it would be for an Indigenous male, and some people are guessing 60, 70 or whatever, 10, 15 years lower. It was actually mid 40s. So there was there was decades of difference between the average lifespan between an Indigenous male and a non-Indigenous male. So those are the gaps, that hospitals are now tasked to look at, measuring and closing those indicators. Recognizing the distinct needs of Inuit, Métis, and urban Indigenous. So this is again a need to fully understand that the experience of a First Nations person on reserve is very different from a non-status person, or an Inuit person living in an urban center. So that's one of the calls to action that hospitals are being asked to put into place, to put some movement behind. Sustainable funding for healing, again, so these positions and these Indigenous health departments are ways to put money into, to demonstrate commitment, right? So you put money behind things that you really value, and you'll see, more and more hospitals doing that with their commitment to these calls to action with the positions that I talked about. So again, the calls to action, Health 22 to 24, recognizing the value of Indigenous healing practices. So you'll see that in like, say, for example, Michaela's room at McMaster here in Hamilton. You'll see that in Brantford General Hospital now, where they have their spaces. There's been some spaces that have rolled out in Niagara area that will support, meeting with those traditional health practitioners and making those medicines and doing those ceremonies on hospital site. All levels of government are called on to increase the number of Indigenous healthcare professionals and to work on retaining those healthcare professionals. So really create a safe environment for Indigenous people to feel valued, working for that healthcare system, and providing cultural competency training. So providing training that will teach people how to operate in a way that addresses racism and bias, stereotypes and prejudice. So really, putting some effort into understanding what that looks like and how you can interrupt that. That's cultural competency training, kind of like what we're going to be doing ahead in the future modules. And medical and nursing schools are being asked to include education on Indigenous health, and the outcomes that we talked about a little bit ago. So people are listening, and we need to, as Indigenous people, it serves those future generations if we can come forward and we can share our experiences and we can use our voice to inform some of these changes that needs to happen. So amongst your group there, I realize this might be something that's just playing to your group, and I may not actually be in front of you, but amongst your group, maybe if you could take some time to talk about how you're feeling after learning about these experiences. Again, like I said, the emotion, really leaning into the emotion is an important part of this transformative work, because that emotion, that passion, it's going to put movement, it's going to put fire under, put a fire under you to recognize that things need to change. Okay, and what can I do to be part of this change? What can I do to be part of this shift that needs to happen? So questions that I suggest that you ask yourselves, these realities. So we talked past about Indian hospitals and residential schools, and we talked about present day realities. So, you know, like the experiences of Brian and Joyce and Heather, you know, those are present realities. The present realities of our people being discharged out into the street in freezing cold weather, you know, all of these things, like these past and present realities, how might they impact the relationships Indigenous people have with the healthcare system, institutions, and care providers today? So I'm asking you to really think about what we've covered and think about what that might mean for, you know, the willingness of Indigenous people to actually go to these institutions, to actually engage with care providers, to actually share information about their experiences. So think about how those are related. So I'm just going to pause here and give you opportunity to have those discussions. And I invite you to pause as well. Okay, I assume you found the pause button and you were able to pause this video while you had that little discussion. I want to talk a little bit about what's coming up next. So like I said, this is a series of videos. This is module 1, so really looking at why we need to speak up and also who's listening. You know, so I'm hoping that by the end of this time that we've had together, you've got a better understanding of what might happen if we don't speak up, you know, the tragic outcomes by just tolerating the influence of racism within the healthcare system, and that the emotions, the passion, you know, what you may have felt working through this information would be motivation for you to take action. In the next module, we're going to look closer at what racism towards Indigenous people looks like in a healthcare space, those relationships and practice. So really digging into what racism looks like, and you know, how can we recognize it within the emergency department, or you know, within those waiting rooms? How can we recognize it in the relationship that I have with this care provider? How can I recognize it in some of the practices that govern the work within these institutions? So whether that's policies or whether it's just the way things are, type of workplace norms, we're going to look into that a little bit next. So there's a little bit of time here for questions, and yeah, so thank you for your time here, and I hope to see you again when we start module 2.